I think we should start now. Assalamu alaikum, good afternoon, and welcome to the Uro Oncology session. I am Dr. Maria Kuptia, consultant medical oncologist and head of the department at Shaukat Khanum Memorial Cancer Hospital and Research Center, Peshawar. Today, I will be the moderator for the session, which will be chaired by Dr. Nushat Kaka Khail and co-chaired by Dr. Mazhar Khan. Dr. Nushat Kaka Khail is a renowned urologist at Northwest General Hospital, Peshawar, and is known to be an institute in himself. Dr. Mazhar Khan, he is director of Institute of Kidney Diseases with more than 35 years of experience to both our urologists. Welcome you all. And so today we have got some highly informative and exciting talks encompassing the medical and urological aspects of urological cancers. During this session, we will have 4 talks, which will be followed by an Q&A session at the end. The first talk will be by Professor Syed A. Hussain on the management of advanced and metastatic bladder cancer. Professor Hussain is a graduate of Dow Medical College, and he completed his general medical professional training in the UK. He did his doctorate in oncology from University of Birmingham. He completed his medical oncology training in Birmingham, United Kingdom, and received his certification and specialist registration in medical oncology. Professor Hussain is professor and honorary consultant in medical oncology at the University of Sheffield and Sheffield Teaching Hospitals NHS Trust. His major areas of interest are management of urological cancers, clinical trials, early drug development, and translations medicine. Please allow me to welcome Professor Hussain at the stage.
Thank you very much, Maria. Assalamu alaikum. It's really a great pleasure and privilege for me to be here. Thanks for the invitation to the Shaukat Khanum Cancer Symposium. It's always great to be here and to talk to my colleagues and think about areas where we can collaborate together. So today I will try to discuss that in 20 minutes, management of metastatic bladder cancer. Over the last 10 years, bladder cancer has significantly changed, and we are seeing multiple lines of treatment. So I will try to give you a flavor for how things have changed, how the survival data has changed, and how more and more patients are living longer with advanced metastatic bladder cancer. These are my disclosures. And just to set the stage, we can see that it's quite common cancer in UK. And many of these patients who present with bladder cancer, unfortunately, die of bladder cancer as well. So mortality still remains quite high. It is still considered, bladder cancer is considered as one of the most expensive cancers because often you will be doing endoscopic surveillance for non-muscle invasive bladder cancer. That means that there are multiple visits to the urology team, and there is an impact on in terms of their quality of life as well. In terms of the outcomes, if we look at that, 1-year survival is 35.7% for patients with stage 4 disease. And that is something I would really like you to remember very well, because I will in the end talk about why many patients are not having any treatment, let alone the amount of different treatments and the different lines of treatment that we'll talk about. And we're really fortunate to be in the era where bladder cancer, which I used to call it a Cinderella cancer, has turned the corner, and we are seeing these patients living longer. So looking through that, if we see that first-line platinum-based chemotherapy is there, then you've got watch and wait with best supportive care or second-line treatment. But these things keep on changing, and now you've got maintenance avelumab treatment. So you don't watch and wait for second-line treatment, but you start maintenance avelumab treatment. Patients who progress on chemotherapy, they have got second-line immune checkpoint inhibitors treatment, and we'll talk about some third-line data with EV and others as well. But I will try to give you a flavor for that, how some of these combinations have made a big difference in the outcomes and how things are improving significantly. So first-line chemo, this is the historical perspective, 14 months with gemcitabine and cisplatin, 15 months with MVAC. But for cisplatin ineligible patients, which is almost 1/3 of our patients, and in many academic centers, there will be more of them, the median survival remains around 9 months. And that's a very dismal figure. Those of us who treat bladder cancer, we quote these figures to our patients that this is how when the patient presents with metastatic disease. Things have changed significantly, and where it really started to make a difference was this trial, because this was the largest trial in metastatic bladder cancer, 931 patients from 128 sites across the globe took part in that study, and that study recruited before time. So it recruited within 12 months. And that trial looked at atezolizumab versus chemotherapy. The primary endpoint was looking at biomarker positive patients because the initial feeling was that PDL positive patients will do better with that, which was not the case because what it showed that PDL positive was only picking patients who will do well, whether they have chemotherapy or immune checkpoint inhibitor, that will not make the difference. In the ITT population, there was difference with the p-value of 0.038. But the important thing with these immune checkpoint inhibitors was the durability of the response. The patients who are living longer, so it's not that it made a big impact on median survival, but I think hazard ratio and looking at the long-term responders at 1 year, 2 years, 3 years is really important in these cancers if you want to make a difference. And that is exactly when I went to NICE to talk about atezolizumab and other drugs. That is how we said, because one of the questions posed to us was about median survival. But we feel what is key here is that how many patients will be seeing down the line, a year down the line, 2 years down the line, and it's the durability of the response that is key here. With the pembrolizumab, similar trial design with pembrolizumab versus standard of care chemotherapy, which was dealer's choice. Again, you saw a difference in survival, 10.3 months versus 7.4 months. And that led to global use of immune checkpoint inhibitors in second-line setting. But things continue to evolve. And I think that is really, because there's some data I will show from last week from ESMO as well, which has really started to make this debate really important and very exciting. So enfortumab vedotin, Nectin-4 targeted therapy, quite an interesting and exciting drug. And it sort of, how it works is that it binds to Nectin-4, then EV is internalized and the linker is cleaved, releasing MMAE, and that disrupts microtubules, which causes apoptosis and cell death. And in the first trial of EV, with the cohort 1, which looked at multiple lines of treatment. So remember, these patients had platinum-based chemotherapy, had immune checkpoint inhibitor treatment, and even with that, you're seeing a median overall survival of 11.7 months. So in third line, fourth line setting, that's a huge difference where we are talking about. Previously, I showed you the slides with first line survival of 9 months in platinum ineligible and 15 months in platinum eligible cases. Then came EV301 trial design, which looked at EV versus pre-selected chemotherapy in patients who had multiple lines of treatment. And this is the updated survival, again, 12.9 months. So patients with multiple lines of treatment with a median survival of 12.9 months. And again, with these drugs, we are seeing long-term survivors. So while the median survival remains very impressive, but what is really exciting is the durability of response, patients who are living 2 years, 3 years, and further down the line with metastatic bladder cancer in third line setting. Progression-free survival was very exciting as well, 38% reduction in the risk of progression. In terms of the adverse events, there were no new safety signals that were seen. Again, between different subgroups, if you look at, it was all favoring enfortumab vedotin versus chemotherapy. Treatment emergent adverse events as well, for example, neuropathy, pruritus. Again, one of these key things when we are using these drugs, it is so important to identify these toxicities, because by identifying these toxicities, you can treat them early, and that helps you for more prolonged duration exposure of the drug to the patient. And that usually translates into improvement in both PFS and OS. So this is something we all have to learn from each other, how to deal with these toxicities at the earliest point to improve the outcomes. Because there are some EV-specific toxicities like skin reactions, peripheral neuropathy, ocular disorders, hyperglycemia. And again, you can see that there are, if you look at grade 1, 2, there's still quite significant toxicities in terms of numbers. But by treating them early, you can make a big difference in these cases. And these skin reactions occur early, and swift management are the key. So if you're looking at any maculopapular rash, you're looking at alopecia, erythematous scaly pruritic papules. If you treat them early, the patient is very likely to have better outcome with more treatments. Things have continued to evolve. People have tried efficacy and safety using combination of immunotherapy, that is atezolizumab in this case, IMvigor 130, which my colleague Enrique Grande more recently presented at ASCO GU as well. And again, that was PFS was the primary endpoint, and co-endpoint was OS. Initial looking at A, which was chemotherapy plus atezolizumab versus chemotherapy alone. The progression-free survival was looking better in this forest plot. Most of them were favoring atezolizumab plus platinum gemcitabine. The p-value was hazard ratio was 0.82 with p-value 0.007. So with a one-sided t-test, so this did make the one of the primary endpoints, but in terms of the overall survival data that has more recently been presented by Enrique, that did not meet its, there was no survival gain. Danube was another trial that tried to add chemotherapy with immune checkpoint inhibitors, and that trial was using durvalumab. And again, that trial with tremelimumab and durvalumab did not show any improvement, 14.4 months versus 12.1 months. So again, at some point, it starts to look like that when you add chemotherapy into immune checkpoint inhibitor, it doesn't work as well because there's no significant survival difference. And here comes Checkmate 901. So those of my colleagues, Maria and others, were there at ESMO. It was really interesting to see. And really, you start to think about what is going on here. Why one immune checkpoint, in fact, two, durvalumab and atezolizumab did not work. Is it something to do with nivolumab, with PD-1 inhibition? Does it make a difference? But this trial was presented by von der Huygen just a couple of weeks ago, which looked at nivolumab plus chemotherapy versus nivolumab. Remember, there are certain differences. And again, there are quite few of our junior colleagues here, and it's just for their benefit. Don't ever read just the abstract. That is very misguiding. Always read the full paper. The differences here are, always think about those differences. This trial had cisplatinum-only patients, while both atezo and with durvalumab, they had both cisplatinum and carboplatin. In fact, if you look at IMvigor130 data carefully in the subgroups, cisplatinum group was significantly better than carboplatin group, and carboplatin actually diluted the benefits in terms of overall outcomes. This is only cisplatinum group, and it was very well balanced that you would expect in a big randomized trial. And what was key point was that the primary endpoint overall survival, 21.7 months versus 18.9 months. So there's not much big difference in terms of survival, but still, this is a large study. It meets its primary endpoint, and this is a positive trial. So with nivolumab in combination with Gemcis, this is the median survival is 21.7 months versus chemotherapy, because these patients who were on chemotherapy, they did receive immune checkpoint inhibitors later on as well. Progression-free survival was again 7.6 months versus 7.9 months. And if you look at immune checkpoint inhibitors, you can see that these patients did receive further standard of care chemotherapy or immunotherapy, like immune checkpoint inhibitors were used in these cases. In terms of toxicity, again, there was no new safety signals that came out with that. And again, it's important. So when you're adding nivolumab with gemcitabine cisplatinum, no additional toxicity came. In fact, there was a quality of life data as well, which did not show a significant difference. So nivolumab was generally well tolerated, and overall outcome looked really good. So while we are looking at this combination, which was just presented last week, there is maintenance data as well, which has been updated more recently, and I will talk to you about that. This is giving chemotherapy 4 to 6 cycles, followed by randomization into maintenance avelumab or standard of care. And again, this is quite an interesting study, quite an interesting data to look at, because what this is showing is, a very well randomized trial, 700 patients in that, looking at cisplatinum plus gem or carboplatin plus gem. So again, remember, this is both for cisplatinum and carboplatin group of patients. And primary endpoint is overall survival. Look at that. So this is the data that was presented in New England Journal of Medicine a couple of years ago, 14.6 versus 22.1 months. What is interesting is that more updated analysis and more updated data shows it 15 months versus 23.8 months. So there's 8.8 months survival benefit. And remember, because I'm going to talk to you about EV302 study, which has been presented last week by my colleague Tom Powles. This 23.8 months, you are looking at this survival figure from the start of randomization into avelumab or standard of care, not from start of chemotherapy. So that's the important point to remember, that all the other studies we talk about we're talking about survival from the start of chemotherapy. This is the study that talks about survival from the start of randomization into maintenance avelumab. So again, for my junior audience and junior faculty, just remember, read these things in detail, because otherwise you look like 32 months median survival with the EV302 data versus 23.8 months. But if you start to add on that 6 cycles of chemo, 18 weeks plus 4 to 10 weeks that patient waited for randomization, that will perhaps be this sort of similar survival we'll be looking at. And the cost, which we'll talk about, hopefully, if you have time in the end, will be quite interesting to think about. So overall survival really favored it in all subgroups. So basically, maintenance avelumab, whether you have cisplatin or carboplatin, is the best thing to do based on that data. And that has been approved by NICE in UK. Many parts of the world use it quite routinely, whether you are giving cisplatin or carboplatin, but as long as you had 4 cycles. And because you require 4 cycles, we have designed a new trial, which is called DISCUS, which looks at 3 versus 6 cycles. You randomize patients between 3 versus 6, because we think patients who get 2 or 3 cycles, they will benefit as well. So we're going to basically analyze that hypothesis within that randomized trial, which we are doing in UK, Spain, and other parts of the world as well, which is recruiting quite well. The key thing in that trial is looking at quality of life, that with 3 cycles, better quality of life with similar outcomes we're expecting. So in the overall population, it achieved longer median progression-free survival as well, which was quite significant in both sort of that data, 2.1 months versus 5.5 months. So you're doubling progression-free survival as well, which is really interesting. A hazard ratio of 0.54. So significant benefit. In terms of the subsequent cancer therapies, patients who are on best supportive care, still you can see they did receive quite significant amount of PD-1, PD-L1 inhibitor. So it's not all muddled by the addition of IO because patients have been offered IO and still there is a big survival benefit. And quality of life remained quite well as well. And that brings me to this EV302 data, which is really interesting. And it was quite, it is a game changer because this is for all patients. While in the maintenance setting, you are treating those patients who are not progressing on chemotherapy. And remember that, how many patients progress on chemotherapy? That's about 1/3, 30 to 35% of patients will progress on chemotherapy. So still maintenance avelumab is an exciting and interesting treatment for about 70% of your treatment with GemCis followed by maintenance avelumab. While this trial is for all patients, but survival starts from randomizing into the trial. And again, looking at PFS and overall survival. So dual primary endpoints in the study, well-balanced key demographics. If you look at cisplatin eligible patients, and similarly, they were cisplatin ineligible, visceral mats, bone, liver, they're really reasonably well-balanced. There is a little bit more of chemotherapy arm has more bone metastasis, which is usually a poor outcome. So again, those are differences, but always look at these things, always dissect the data. Don't just feel that because they said this is the new standard of care. Always look at your own, try to put your own understanding into that as well, that why this data could be. And again, just remember, this has not yet been published. So it was presented because the final data came literally 2 weeks before the meeting. Progression-free survival, again, was significantly better, hazard ratio 0.45. In bladder cancer, we had not seen these sort of data. So there's a very real reason, and that's the reason it got standing ovation and was really hailed as a big, big new change, because we had not seen this sort of data in metastatic bladder cancer patients. And the overall survival, hazard ratio 0.47, 16 months versus sort of 31.5 months. So this is big change and doubling of the overall survival. So that tells us that actually more of our patients will be living longer and making a big difference. Overall, if cisplatin eligible or cisplatin ineligible, in both cases, hazard ratio 0.53 for eligible and 0.43 for cisplatin ineligible. So it is available for all patients from the start. You don't have to wait for patients to progress or not progress before you give avelumab, or you give atezolizumab if they progress on first-line treatment. And in terms of the confirmed overall responses as well, what is key here is that why is that overall response so good is because there is some chemotherapeutic. These drugs are not just conjugate antibodies targeted treatment, but they act more like chemotherapy. And that's why some of the side effects you see as well. And then 59% of patients chemotherapy received PD-1, PD-L1 as well. But in terms of the platinum-based treatment, if you look at the total number of patients who are getting avelumab and things, we would expect them to get more patients to get maintenance IO and things than that was presented. Treatment-related adverse events were generally well they were class effects from chemotherapy, class effects from EV plus pembrolizumab that we saw as well. So chemotherapy, febrile neutropenia, MI, neutropenic sepsis, and sepsis Similarly, there were EV treatment-related adverse events like skin reactions, neuropathy, sensory events, motor events, ocular disorders, some of those events that we talked about earlier. And I think where I really wanted you to think more about was this slide, because that is important for all of us in this room, because there are patients who are not being treated at all. We have talked about the median survival changing in first line, second line, third line. We're talking about third line EV 12 months. And here we are, we're talking about data from Europe. And I think that's where I will encourage some of the junior colleagues who are here, who have spoken to me, think about, bring that data out, see how many patients with metastatic bladder cancer come to your clinics and see how many of them are treated. If they're not treated, is it because of poor performance status? Is it because patient declined? Is it because of cost factors? Just document these. These are the abstracts that ASCO and ASCO GU will love from us. And I think that's what I would like you to be, and I'm always happy to be contacted to talk about these. But this is something that we should put from our countries as well, from Pakistan, from Middle East, from other parts of the world, because this is the big elephant, because percentage of patients not receiving any treatment, while we're talking about first line, second line, third line, it starts to become completely impractical when you see half of the patients are not even being treated with first line. Is it delays in diagnosis? Is it delays in treatment? Is it delays in cost issues being sorted? And I think that is where I want to say that, this is how things are. If they're cisplatin eligible, GEM-CIS, if you're looking at neoadjuvant, adjuvant setting, adjuvant nivolumab, maintenance avelumab, but those unsuitable for maintenance IO or decline treatment, second line IO, EV plus IO in trials, is it the new standard of care? And I do want to put a question mark in, because the slide Andrea Apollo put and some of my other colleagues have put, they have called this as the new standard of care. But I'm talking here, and I'm talking here not just in Pakistan, but also in UK when I'm talking about it. I'm saying that we may not be able to afford this drug, EV plus Pembro, because I've been to NICE many times with different drugs, and I know what is the cutoff for the cost of these drugs. And this EV plus Pembro, if you remember the design of the study, it is up to disease progression. So can I have just one more minute? Yeah. It is up to disease progression. It is not till, up to disease progression or death. It is not to stop at 4 cycles or 6 cycles. And that again gives a great idea. I think we are planning escalation and de-escalation studies. Should we stop at 6 months or 12 months of EV? Because that is what is significantly costly. So if you have any patients, even with the small numbers, try to get that data together from Pakistan and say, actually, we have already done that study because many patients could not afford after 3 cycles. And what happened to them? What was their PFS? What was their OS? So I think there are a lot of these trials that we're doing. Similar is for cisplatin ineligible group as well. But I will say number of trials that we have done and recruited would not have been possible without my colleagues, my urology colleagues, Jim Cato, Aidan, Derek Rosario, a lot of my research nurses that you can see here. And again, they are the key players because we work as a team in oncology, and the Macmillan nurses, the clinical nurse specialist, they play a key role here. So I think I just wanted to acknowledge all of my colleagues and team here, and where we have been really successful in putting patients in all these clinical trials is because of a joint Uro Oncology clinic, which I'm a big proponent of. And I will suggest to you guys as well that if you start to have where a urologist and oncologist are not doing same clinic, but me and Jim are sitting in different rooms, but we are next to each other, and patient flows between my clinic to his clinic and his clinic to my clinic, which means that sometimes when the trial lines are quite small, short, tight deadlines, we are still able to get these patients into these treatments. So I think on that note, I will stop. We'll be very happy to take any questions at any point. Thank you.
Thank you, Professor Hussain, for such a comprehensive talk. So now we will move on to the next talk, which is an online talk by Professor Nicholas James on emerging challenges in metastatic prostate cancer. Prof. James is a professor of prostate and bladder cancer research at the Institute of Cancer Research and the Royal Marsden NHS Foundation Trust, London. He was previously professor of clinical oncology in Birmingham until 2019. He is also an NIHR senior investigator and deputy dean of the Institute of Cancer Research. Prof. James is chief investigator on the groundbreaking STAMPEDE trial, which has been used to evaluate to date 10 different therapies for advanced prostate cancer in around 12,000 men. The trial has shown that big survival gains can be made by using existing treatments in novel settings. In addition to being involved in the science, he has also remained actively involved in the art, education, and logistics related to access to prostate cancer treatments. Welcome, Dr. James.
Hi, good morning, or good afternoon, whatever time it is with you. I thought you were
I'm going to talk about emerging topics in metastatic prostate cancer. I'm very sorry not to be with you in person to give the talk, but I think we will be connecting towards the discussion part of it. So this is the overview of what I'm going to talk about. I'll give you an overview, very brief, of hormone-sensitive prostate cancer, and then I want to drill down into areas which I think are very interesting and which help to drive therapy choices. So the first of these will be volume effect. For both docetaxel and AR-targeted therapies, and as I'm sure you're aware, they are different, these two classes of drugs. I'll then look at the effects of radiotherapy in metastatic disease, focusing mostly on treating the primary rather than on the role of SAVOR, it's just not enough time really. And then finally, I will have a look at the effect of new generation imaging on our decision-making processes. So 20 years ago, prostate cancer was very simple. Men tended to present with advanced disease. I mean, there was PSA screening going on, but if you presented with metastatic disease, either locally advanced or metastatic, you were started on long-term androgen deprivation, and that was about it. When you relapsed, you were referred for palliative care, but weren't really very much in the way of options prior to 20 years ago. 20 years ago marked the appearance of docetaxel and 21 years with zoledronic acid, but prior to that, was really very little. So we've got a hugely changed landscape now. We've got a whole range of different drugs that work in relapsed disease, a whole range of androgen-targeted therapies, some with broader approvals than others, but broadly they're all the same sort of target and same sort of effect. We've got two chemotherapy drugs, docetaxel and cabazitaxel. Arguably, we could probably add platinum compounds as well for men with BRCA1, BRCA2 and related mutations. Two radioisotope treatments, radium-223 and PSMA lutetium. There are, of course, older treatments like strontium and yttrium, which we are no longer using, but I guess we could have them on the list as well. And PARP inhibitors for men with relevant DNA damage repair mutations. We've also known for quite some while for some of these drugs that if you shift them from the relapsed setting to the upfront setting, they get a bigger survival improvement. So this was first shown for docetaxel by the CHARTED and STAMPEDE trials, and then subsequently for abiraterone, again by STAMPEDE and by the LATITUDE trial, and more recently in various settings for enzalutamide, apalutamide, and darolutamide. There's also the separate question of giving radiotherapy to the primary. Two trials using radiotherapy with agent C, STAMPEDE and PORAD, showed survival improvement in low volume disease. More recently, PEACE-1 has produced a slightly confusing result, which I'll go through, but I think broadly it's compatible with the survival advantage as well if you combine radiotherapy with abiraterone, which was the predominant setting in that trial. But I'll come back to that. So, could all metastatic disease get the same treatment? Well, I guess clearly, just from what I put on the previous slide, the answer is no. We've got a couple of obvious subgroups, DNA damage repair mutations and low and high volume disease that split up the options. So starting with volume effect, these first started generating discussion following the charted trial results, where although the headline result was positive for the whole trial, there was a suspicion, much emphasised by Chris Sweeney, that it was really only working in the high volume disease and not in the low volume disease. And this subsequently prompted Chris and others to have a look at survival in different volume groups in a couple of settings. So on the left is data from a pooled analysis of chart and jet of 15 by splitting in two ways. Firstly, my metachronous versus synchronous metastatic disease, that would say metachronous disease that appeared a while after the primary treatment, either surgery or radiotherapy. And the second is splitting by low and high volume using what has come to be labeled the charted criteria, but actually it was described in an earlier RTOG trial. And essentially 3 is the magic number. 1 to 3 mets is low volume, 4 and above is high volume, with a couple of bits around laterality that happens. But anyway, if you use that 4-way split, what you see is distinctly different prognosis for de novo high volume compared to metachronous low volume, which has a strikingly much better prognosis, with the two sitting in between. This is data from SEER, US Hospital Registry, making essentially the same split by volume and timing of metastasis. And again, we see the same effect. So metachronous low volume does much, much better. Synchronous high volume does the worst. So it's a pretty consistent prognostic pattern, but does it help you select treatment? So this is the best data. I'm not going to wade you through all the different various publications. So our group, led by Claire Vale, who heads our meta-analysis groups, pulled together the 3 key trials here, which are Stampede, Jet of 15 and Charted, and then split the patients 4 ways. And this is progression-free survival. And what we can see in the top left-hand corner is low volume metachronous disease has a pretty good prognosis and no real effect. This is plus or minus docetaxel. All of the other groups, there is a clear docetaxel effect of varying sizes. You can see high volume metachronous disease is actually quite uncommon, but you've got a very clear benefit in synchronous metastatic disease, both low and high volume. And I think this is probably the definitive answer on this. Now, by and large, we wouldn't recommend docetaxel as the sole therapy on top of ADT anymore because of the results of PEACE-1 and Arasens, which I'll come to. But I think this is important because if you're going to add an AR targeted therapy on top of docetaxel, I think you need to be clear that the patients would be getting benefit from the docetaxel component from it. So this group really don't get much convincing benefit. And if we look at the same data a different way, splitting up by the 4 groups and look at the progression-free survival and the overall survival, there's really no hint of a benefit. If anything, there's potentially harm from docetaxel in this group, whereas you've got clear benefits on progression-free and overall survival in the bottom group with the same intermediate effect in between. The other thing with docetaxel is what happens if you go into the high-risk non-metastatic setting, and 2 trials, again, Stampede and SF12, really show no convincing docetaxel in the M0 setting. So summing that up, no benefit in M0, no benefit in low volume metachronous, but there is probably robust survival benefit in the other groups. So moving on to AR targeted therapy, and again, I'm not going to go through all of these trials in detail, I'm sure they're well known to you. But basically, there's a whole range of trials that show improved survival in hormone-sensitive metastatic disease with abiraterone, enzalutamide, apalutamide, darolutamide. Now, these have variable use of upfront docetaxel. So the first 2, Stampede and Latitude, no docetaxel upfront. Enzamet, Arches, Titan, and Arasens, which I'll come back to separately, had variable levels of docetaxel at the base therapy. And so this is the interaction with docetaxel. There are 3 trials here, really, that drive it: Arasens, PEACE-1, and Enzamet. And for 2 of them, not for Enzamet, you've got a survival advantage, and mostly that seems to be driven by the high volume component of it. So if we look in PEACE-1, where they did do the split high versus low, the benefit is in the high volume. The data in Arasend is a bit less clear cut than this, but the data here really shows in the subgroup analyses, of course, no benefits. There's no benefit in the overall group. So summing up these effects, we've got different effects for different groups. We've got a prognostic effect by volume in all groups, but a predictive benefit only for docetaxel and radiotherapy, which I'll come back to. And that is for failure-free and overall survival with docetaxel. But what happens if we go into M0 disease with AR targeted therapy? So there's currently only one mature trial in this setting, which is the PED. And just to remind you again, there was no benefit in this setting with docetaxel. This is the inclusion criteria for the M0 part of PED. So either at least 2 of T3/4, PSA above 40, or Gleason 8 to 10, or node positive. There was variable use of radiotherapy, so node positive patients, this about 50-50, radiotherapy, no radiotherapy. For the relevant time period here, all the node negative patients, i.e. this group, got radiotherapy, and they only got 2 years of treatment. So this is the time window we were recruiting to this in, and there's a second cohort who had abiraterone plus enzalutamide, and we did a sort of pooled meta-analysis of 2 groups. So this is the pooled result. So you've got a very robust metastasis-free survival benefit for abiraterone with or without enzalutamide, and the enzalutamide didn't add anything apart from toxicity. In fact, you can see this is a highly statistically significant result, and the 6-year metastasis-free survival improved by 13% in absolute terms. In overall survival, the effect is also robust, which we would expect, as MFS should be a surrogate for OS. And again, you've got a 40% improvement in overall survival with an absolute improvement of 9%. Of 9% at 6 years. So a highly worthwhile gain in the M0 setting. So summarizing AR targeting therapy, we've got no volume effects. It works in high and low volume synchronous metastasis in the metastatic setting. And for the one trial where we do have data so far, that benefit extends into high risk M0 for abiraterone. So moving on, can we combine AR targeted therapy with docetaxel? I've touched a bit on this already, and there are no trials where AR targeted therapy was the control and docetaxel was added on top, but there are a range of trials the other way round. So the first to report was PEAK-1, which is a 4-way randomization between ADT abiraterone, the same plus radiotherapy and both. And because this trial was recruiting when the docetaxel results came out, patients could have ADT plus docetaxel as part of their standard of care. So it's quite a complicated mix of different treatments, and that has to be borne in mind. So there were interactions between some of these treatments for reasons of volume, for example, but not others. So this is the randomization for patients where the base therapy was ADT plus docetaxel, and we're looking at what the effect of is adding abiraterone. And we can see that is statistically significantly in favour of triple therapy, if you like, DOSI, ABI, ADT versus ADT, DOSI only, and 25% gain with a significant p-value and clear separation of the curves. The second trial, Arasend, was designed exclusively to test the question of adding an AR therapy on top of docetaxel, the 2 treatments starting simultaneously. And again, the primary endpoint is overall survival, and it's a positive trial. So this is data that Matt Smith presented and published in the New England Journal of Medicine last year. Clear survival advantage, hazard ratio of about 0.7, so 30% gain with darolutamide in this setting. Just in terms of what the benefits are, though, it's worth thinking about what the quality of life benefits are of adding docetaxel to an AR targeted therapy. And we've got data on that from Stampede, where we've got overlap between the abiraterone recruitment and the docetaxel recruitment. And this is a head-to-head comparison of quality of life from contemporaneously randomized patients on the docetaxel arm, the control arm is the black line, or abiraterone. And what we can see is that abiraterone consistently improves quality of life compared to the control therapy. We didn't put the confidence on the graph. Abiraterone, docetaxel in contrast, decreases it, which is not a surprise. But the thing that was a surprise was the duration of the impairment. So it's reasonably predictable. If you go from a doublet therapy of ADT-ABI to, or similar to ADT-ABI and docetaxel, that you're going to drag down quality of life for quite some considerable period of time. So you've got to be confident that you want to give these patients docetaxel. So in summary, the data on triplet therapy, triplet versus doublet, is mixed, with Enzamet being mostly negative. I mean, there is a suspicion that's positive in the high volume synchronous setting, which I know is Chris Green studied off from this. I know that's what he'd say, but that is not the primary analysis. There will certainly be a quality of life penalty from triple therapy compared to AR targeted double therapy. And so I would say it's probably most suited to younger high volume, and I would add synchronous to that as well, patients. So what about radiotherapy for metastatic disease? So I'll show you the Stampede data. So we split the patients into newly diagnosed metastatic. Standard of care included docetaxel for about 20% of them, and this was stratified. And then we had two different high-dose palliative radiotherapy schedules, if you like, not full radical. And what we saw was there were different effects in the low burden and the high burden, with benefit in the low burden, no benefit in the high burden. And so this is the effect on failure-free survival, big effect here, no effect here. And this is the effect on overall survival. So statistically significant here, no difference there. And we did an analysis by metastasis number, and there's a linear relationship between the number of metastases and the magnitude of the benefit, with the benefit being biggest in the 1 to 3 metastasis group, the charted low volume group being shaded in here. Piece 1, again, you've seen the design already. So you've got the possibility of combining these two with these two. So you can do a 2x2, or you can do a 4-way analysis. And some of the tests interacted, some of them didn't. So some of these analyses are presented 4-way, some of them are presented 2-way. The paper is not out yet. So this is a radiographic progression-free survival, and no real differences here, which is surprising, but the numbers here are actually quite small. But you've got a very clear difference here from adding radiotherapy on top of abiraterone. If you look at time to castrate resistance, and these are pooled, again, the benefit is really quite obvious and quite marked, with a highly significant p-value. And this is time to castrate resistance split 4 ways. And again, you've got some benefit from radiotherapy here, a bigger benefit from abiraterone, and the biggest benefit from the other version of triple therapy, which is ADT, abiraterone, all combined. Also, very importantly, this is time to serious genitourinary events, and big benefit here from upfront radiotherapy. Again, if you split 4 ways, the benefit is there, and this time the radiotherapy is helping, it's possibly better with abiraterone in terms of effect on long-term local control. And this is in the whole population, not just the low volume, and the effects are persistent. So this is separate evidence that is potentially worth adding radiotherapy for at least selected patients with higher volume metastatic disease in order to prevent late genitourinary complications. And this is data that we're going to present at ESMO. So it's not actually out yet, so please don't fight this, because I think we're presenting this before we presented at ESMO. But basically in Stampede, we're seeing the same effect. This is taking a single aspect of this, which is the need for nephrostomy tubes. And again, you halve the need for nephrostomy tubes with upfront radiotherapy, this in the Stampede M1RT comparison. So the radiotherapy does improve survival, but only in patients with low burden disease. And then there's a piece 1, there's the second question, what the interaction is with abiraterone. But it looked to me like the triple therapy combo of abiraterone, AET, and radiotherapy is looking like the best combo. It's certainly well tolerated. I haven't shown you the toxicity data. Now, what happens if we add in new generation imaging? And I'm going to start by showing you 2 case histories, which For the first one, the patient presented with a couple of bone mets, or 1, 2, maybe 3, possibly 4, maybe not, but anyway, certainly just a few metastases. So he is low volume as per the charted criteria, so therefore should get prostate radiotherapy. On the other hand, when we did a PET scan, you can see he's got a huge volume of disease, and just rotate this, you can see the very extensive disease. Most of these don't show up at all on either the CT or the bone scan component. 1 or 2 mets like this one does show up on both. So how should we treat him? Is he low volume or is he high volume? Second patient also presents with a couple of metastases. So he's got 1 here in his spine and 1 here in his pelvis. And we also did a PET scan on him, and those are the only 2 metastases. So apparently the same setting, a couple of metastases on conventional imaging. One's got lots and one's got very few metastases on the PET imaging. So if we've got a sort of schema where at the left-hand end we've got localized disease, we're going to treat with radiotherapy and ADT short-term, or surgery, of course. As we go across node-positive disease, we're going to give prostate and nodal radiotherapy, probably an AR-targeted therapy as well now. Now we've got oligometastatic disease, gets more complicated, high-volume metastatic disease, maybe adding docetaxel. But what happened? That's on conventional imaging, but once we add in the bone scan, the new generation imaging to the bone scan, some, as I've shown you, but not all, as I've also shown you, will move to the right. So what do? Do we drop things out? Do we add things in? We add in para-aortic nodal radiotherapy. For example, here he's now got para-aortic mets instead of just pelvic mets. We just don't know. There's no trials. So this is my last slide. Just some conclusions. So what do I think is the current standard of care and what's under evaluation? So I've picked 5 metastases as the cut point for SBRT. That's the cut point we've picked for Stampede 2, where we're going to test SABRE2 metastases. So I think the current state of play is they get ADT, they get an AR-targeted therapy, and they get prostate plus or maybe pelvic nodal radiotherapy. And these things are being investigated. So PARP maintenance, metastasis-directed therapy. And it's worth considering whether patients should be stopping treatments at 2 years, because these will live a long time as per the meta-analysis instances I showed at the beginning. You've got metachronous low volume disease, you've got a particularly good outcome. And in our practice, we mostly offer these metastasis-directed therapy and short-term or even no AR-targeted therapy. And so we don't start this group anymore in my practice on long-term ADT. If you're polymetastatic and synchronous or metachronous, it looks quite similar in terms of systemic therapy. There's a number of trials that have been, including Stampede 2, either looked at or looking at upfront PSMA lutetium. Again, PARP has been looked at in this setting. There is a question, if you downstage somebody and only the prostate is lighting up on PET, should you be giving consolidation radiotherapy to the prostate? Another interesting question. So in conclusion, I think nowadays metastatic prostate cancer should be separated into low and high volume and synchronous and metachronous, so 4 boxes. And the low volume metachronous disease has such a strikingly different prognosis, particularly if it's low volume detected on PET only. But I think these patients need to be de-intensified, less ADT, less of everything probably, because they're going to have a long survival and you could do a lot of harm with long-term ADT. On the other hand, the sort of opposite corner, high volume synchronous, has a very poor prognosis, and further intensification strategies are appropriate here, I think. That's my last slide. Thank you very much for your attention, and I look forward to taking questions live shortly.
Thank you very much,
Good
Prof.
afternoon.
James.
My name is Nick Shepherd, Professor of Prostate and Bladder Cancer Research.
Thank you very much, Prof. James, for sharing these emerging concepts in the management of prostate cancer. So now we will move on to another online talk, which is being delivered by Dr. Hassan Kazi on the role of robotics in contemporary urology. Dr. Kazi is a consultant. Dr. Kazi is a consultant urologist with subspecialist interest in robotic surgery for prostate and kidney cancer, and is a high volume surgeon. His initial appointment was as a consultant urologist in Glasgow in 2013, where he set up laparoscopic pelvic cancer surgery and went on to establish the robotic prostatectomy program for the West of Scotland. There he trained a team of doctors, nurses, and physiotherapists for a large regional service prior to moving to St. George's University Hospital, London in 2017. He is actively involved in teaching and training at a number of international courses, and course director for the innovations in laparoscopy, and trained over 250 experienced urologists from across the Europe. Welcome, Dr. Kazi.
Assalamu alaikum, everybody. My name is Hassan Kazi. I'm a consultant urological surgeon at St. George's University Hospital, London. And it's a pleasure to join you all today, albeit via a video link. I'll be talking to you regarding the role of robotics in contemporary urology. My own background is that I trained in open surgery in the west of Scotland. I was a Glasgow-based urological trainee. I started upper tract laparoscopy towards the end of my training, so I could do independent kidney surgery. I then went for a fellowship in laparoscopy and robotic surgery to Germany. There were just 5 sort of big high volume centers doing that sort of stuff at the time. And upon my return, when I got my consultant job, I started off doing laparoscopic surgery, and I then converted to robotics. And the robots that I've had experience with are the Da Vinci SI, followed by the XI. In St. George's Hospital, where I currently work, we have 2 robots with a dual console, which make it extremely convenient for both the trainer and the trainee. Now, traditionally, when I was being brought up, there were lots of comments being made about limitations of minimally invasive surgery. And over the next 15 minutes, what I would like to demonstrate are the lack of limitations of robotic surgery, certainly in this day and age. I'll talk a little bit about prostate, kidney, bladder, and reconstructive surgery, and I'll use my own center here in London as an example for what we can do using robotics. Now, as we know, robotic prostatectomy was the first real robotic operation that was pioneered. The first one was done in 2001, and it involved working in a very small space, and it's a very well-established technique. I've done over 1,000 robotic prostatectomies, and it is something that one does day after day. However, a robotic prostatectomy is not just a cancer operation, but I think we have to look at things in terms of the trifecta of outcome: margin status, preserving continence, and potency. And it is beyond doubt that with robotic surgery, one can achieve each of these 3 in a much better way. We last done a non-robotic prostatectomy in St. George's Hospital back in 2012. So for the last 11 years, over the last 2,000 cases, we haven't done a single one using anything other than robots. The margin status, which translates into a negative PSA and the reduced risk of disease prolapse, is absolutely superior. In terms of continence, certainly in the population I'm sure you deal with, maintaining continence is extremely important for various reasons. We did over 200 prostatectomies at St. George's last year, and the number of patients who were fitted with the urethral sphincter for our population was just 3. So with sophistication, the continence is preserved very, very well, certainly due to sphincter length and fascia. And again, potency again can be preserved, certainly in high volume centers with high volume surgeons. Nerve-sparing prostatectomy has excellent outcomes in being able to preserve erections in suitable men. But the other thing I would like to say is that as one is able to do very sophisticated prostate surgery, You've also then really got to up your game in terms of your prostate diagnostics. So in 2017, I set up a single stop clinic where all patients with an elevated PSA have a contrast-enhanced multiparametric MRI. We see them with the results within a couple of hours. And we do a local anesthetic targeted transperineal prostate biopsy where appropriate. And we also recognize that because we are able to preserve the nerve bundles and really plan surgery extremely well, targeting lesions and being able to find out where the prostate cancer is becomes extremely valuable. And this certainly has been published, and this has won a number of accolades. So you can always start robotic surgery as the driving force for a much bigger change for your diagnostic stream. And again, one of the popular things that has happened as you become a high volume center is that you attract world-leading trainees from different parts of the world. Certainly, that was a treat during the pandemic. We are a European and a Royal College of Surgeons recognized training center, and we get people from all over the world. And it's very satisfying to be able to train trainees to a high standard under our care. Well, what about non-cancer robotic prostate surgery? So again, we have one of the world's largest experiences of robotic simple prostatectomy. Well, it's a modified Millens. We've done about 130 so far. 2 people of the 130 had blood transfusion, and 0% have had any stress urinary incontinence beyond the first 3 months. So the results functionally are very, very good. It is only undertaken for patients whose prostate glands are over 100 cc's. However, our average prostate weight is 270 cc. It started off because we did not have OLEP within the hospital. So we have a large Afro-Caribbean population of men with very large prostates. And we started off with a catheter-dependent population. And again, this is just one example. So this chap had a 205 cc prostate gland. He's also got prostate cancer, and he had a surveillance MRI scan for a small PARAD4 lesion there. And you can see how nice the cavity is following his robotic simple prostatectomy. And these are just a few of the specimens that I have been removing over the last few years, I would say. So essentially, one can follow the adenomectomy plane and yet excise the vast bulk of prostatic tissue with amazing results, both in terms of continence. There's no impact in terms of erections. And as I said, long-term urinary leakage is exceedingly rare. The largest one I've done was about 500 milliliters. But again, as I said, the average weight over 130 is between 250 and 300 grams. The other advantages, if you've got a number of bladder calculi, you can also use your robot to remove those, or you can treat bladder diverticularly at the same time. Now, moving on to renal surgery, again, there has been a transformation. So again, when I started off, I was doing open partial nephrectomy and laparoscopic nephrectomy. However, things have now changed, and progressively, we are even doing radical nephrectomies, including lymph nodes, etc., all using the Da Vinci robot. Now, this is a split that's provided by Intuitive, who market the robot. But in 2017 and 18, this is a look at the total number of robotic operations done. So of the total number of prostatectomies done, 84% were done robotically, while the rest were done as open or lap procedures. That number has shrunk significantly in the last 4 years, and it's less than 5% now. Partial nephrectomy, well, 65% was being done robotically, and the remaining through other techniques. And cystectomy was about a 50-50 divide. But again, certainly in our hospital, as I'll demonstrate, things are rather different. Now, in St. George's Hospital, we have been doing 100% of our partial nephrectomies over the last 5 years using the Da Vinci robot. We are unable to undertake much more difficult, complex renal tumors. So nephron-sparing surgery unequivocally better. This, unfortunately, was an error in capturing data. It says that 95% of our prostatectomies were done using the robotic approach. Well, in reality, we've not done a single prostatectomy using anything but the robot over the last 10 years. And of course, things are also spreading. So We have two robots. One is for urology, and the second one is a multimodality robot for the number of different specialties, from thoracic surgeons to colorectal surgeons, ENT, etc. And of course, robotic upper tract surgery includes not just robotic kidney surgery, but you can also do a very elegant para-aortic node dissection using the Da Vinci robot. So you can take on much more complicated stuff. And again, certainly in our organization, we have published this as a standardized technique. Now, moving on to non-cancer upper tract surgery, again, as you would know, robotic pyeloplasty, commonly done, and it makes suturing extremely easy. Functionally, the outcomes are very good. And we've also been very comfortable doing robotic upper tract reconstruction. So various crossover techniques, etc., which I will explain in a little bit more detail later. But the Da Vinci robot can be used for everything from urethrolysis to upper tract recon. And again, this is demonstrated. We have trained people. We have a modular training program, and this is reproducible to a very good standard. Now, moving on to radical cystectomy, our journey started about 10 years ago. And interesting to note that certainly in my center, over the last 4 years, we have not done a single cystectomy as open. They are all done using the Da Vinci robot. I don't undertake cystectomy myself. I have a wonderful colleague, Rami Isa, who does cystectomies. But again, we made the conversion a few years ago, and not a single one has been done open. Because their peri-procedure journey is much easier, you can undertake cystectomy in a much older cohort of patients as well. So again, just as an example, we had 3 patients over the age of 87 and a very large number of octogenarians as well. So cystectomy, certainly when I was training in open surgery, was normally not undertaken for people over the age of 80. But certainly that has changed over the last few years. A number of these patients are quite frail. So certainly in terms of our hospital, we are at sort of the upper end of the curve within the NHS. But about 4% of people are significantly frail. The risk of conversion to open procedures is 0% in our hands. And again, we can demonstrate that as you do a higher number of cystectomies, that's us there, the number of major complications also drops quite significantly. And again, a touch under 20%. So about 80% of people will escape unscathed following a cystectomy. And that goes for emergency readmission as well. So our emergency readmission rate within 30 days is in the order of 2.5%, which, given what a major operation it is very, very good. And again, the risk of death within 90 days is, again, extremely low. And this reduces as you get more and more volumes coming through. So in essence, cystectomy is made much, much simpler. And again, we do cystectomy and intracorporeal neobladder as well within our organization. Sorry, that video isn't projecting particularly well, but just to demonstrate, you don't need to do anything extracorporeally once you get used to it. Now, in addition to cancer surgery, again, for the lower urinary tract, we do all bladder diverticulae using the Da Vinci robot, and you can treat multiple diverticulae at the same time. And again, it makes life so much more easy. The same goes for ureteric strictures. So these could be following a number of different reasons, but we do ureteric reimplants, Boari flaps, psoas stitches, etc., routinely using the Da Vinci robot. And other than emergency surgery, we haven't done a single one using the open technique for about 5 years now. And finally, you may be aware that meshes for stress urinary incontinence were banned in the United Kingdom following a number of issues. So a few years ago, my colleague Jay Seth, we decided to think about doing Birch Colpo suspension robotically. And again, I'll demonstrate. We've done quite a few of these, and they do extremely well. Again, we can use the Da Vinci robot for a number of other indications, severe pelvic endometriosis. So we work with our gynecologists, and we've removed a number of large cysts and other lesions. Metalwork eroding into the bladder is another one. So this patient had the bladder trapped. So the right inferior corner anteriorly was trapped following some metalwork. And again, we were able to mobilize, do a small partial cystectomy, and resuture everything very, very appropriately using the Da Vinci robot. So our experience of robotic reconstruction is quite significant. We've done about 80 colposuspensions, augmentation cystoplasties about 10, about 60 ureterectomy implantations plus minus distal ureterectomies. Robotic simple prostatectomy, we've done about 130. We've done hernia repairs, 35 diverticulectomies, over 100 pyeloplasties, a number of diversions, and fistula repairs. So what I would say to you is that in essence, robotics is a complete game changer. The learning curve is absolutely shortened compared to laparoscopy and open surgery. Certainly in my own experience, I think that the difference between an exceptionally talented surgeon and a ham-handed surgeon is really narrowed down, which means it reduces variability in your surgical outcomes. It does allow complex procedures to be undertaken using minimally invasive surgery, including extensive lymphadenectomy and very complex surgeries in fairly small spaces. And another big important factor is that at the end of the day, your back doesn't hurt, you stay fresh. And if you do, for example, 3 major cases in a day, the difference between the first and the third case is negligible. So happier surgeons equal happier patient. And yes, I would say that robots are awesome. Human beings are okay as well. So I appreciate that there are financial concerns, but there are a number of robots in development. And however much you can, I think if you could somehow incorporate robotics in your practice, it would be very, very beneficial. Thank you very much.
Thank you, Dr. Hassan, for such a wonderful talk. Now we will move on to the next talk, which is SPRT for localized prostate cancer by Dr. Muhammad Ali. Dr. Ali is a radiation oncologist working at Peter MacCallum Cancer Center, Australia, and is a PhD candidate at the University of Melbourne. His main areas of interest are genitourinary and head and neck malignancies. His areas of expertise and research include the role of stereotactic body radiotherapy for kidney, prostate, and metastatic disease.
Yeah. Thank you, Dr. Maria. So it's always pleasure to be back at Shaukat Khanum. So I did my first training for FCPS at Shaukat Khanum, spent 2007 to 2013. Before moving to Middle East and then eventually to Australia. So today I'm talking about stereotactic body radiotherapy for the prostate cancer. And we don't have a lot of radiation oncology in the hall. So I will cut my presentation short and will take out the, I know you, so we can discuss later on. So I was planning to go for 3 main areas. One was the clinical outcomes. What are the data we have so far? What is the tumor control and physician-reported or patient-reported outcome? And then the next phase was, can we reduce the toxicity by managing the motion or reducing the margin? So I will skip these to try to limit to 10 minutes. And then we will go on further for the future. So if we look at the radiation journey for the prostate cancer, So in 60s and 70s, before the advent of CT scan, the treatment was 6.5 weeks, which was most safely delivered based on body surface or fluoroscopy. Then in 80s and 90s, with the advent of CT and using CT scan in radiation planning, we came to know from multiple RTOG, European and Australian trial, like the minimum dose is 74 gray plus, which can be delivered over 8 to 9 weeks to get the maximum control. And then from early on, start of this century, we realized the alpha beta ratio for the prostate cancer is quite low, and we can further cut the treatment duration to 4 weeks. We have more than 5 trials, but the most common and most famous one was the CHIP and PROFIT. And we reduced the treatment from 8 weeks to 4 weeks. And now over last 10 years, the main focus is, can we further reduce it down? And if we look at the current NCCN, and this is there for last 4 or 5 years, that the minimum duration is 4 fractions. So 4 to 5 or even up to 7 fractions are considered standard of care. And as we will go through the next few slides, we will see that these guidelines were basically in the era of COVID, we incorporated it into our practice before having any good phase 3 data. So the first trial, which was the hypo-RT trial, it was done in 2 countries. One was the Sweden and Denmark. So this one was not a current standard SBRT, but it was mainly giving us the insight of delivering higher dose per fraction, which was more than 6 gray per fractions. So they randomized 1,200 patients into conventional 7 to 8 weeks of treatment versus 7 treatment, which was 6.1 gray in 1 fraction. They used 3D conformal radiotherapy, which is not being used in current SBRT, and we use VMAT in it. So what we have looked, the 5-year outcome, they reported 84% biochemical control. And we need to know that this survival was relatively lower compared to the other reported literature, which was more than 90%. But the reason was they didn't allow ADT in this cohort. So if we give ADT, which can add extra 5 to 6% of biochemical control in this cohort. But the important thing was they have reported 5-year toxicity of very low, which was 5% in 7 fractions and the same in 20 fractions. Grade 2 plus GI toxicity was very minimal, and it was 1% in each group. The patient reported outcome, if we look at the bladder function and the wall function, if we look at both curves, you can say it's more or less overlap each other. So there was no significant difference in terms of quality of life for all the patients. Then the current standard SBRT, which is 5 fractions delivered with VMAT. So this was a meta-analysis which involved 7 phase 2 trials of 921 patients delivering 35 to 40 gray in 5 fractions. And what they have reported that at a median follow-up 3.1 year, the late grade 3 plus GU toxicity was less than 1%. And similarly, grade 3 plus GI toxicity was minimal as well. And the biochemical control was 3 year was more than 95% in low risk and the intermediate risk. Then the most recent, this is the PACE-B trial, the largest phase 3 trial reported for current standard SBRT. It was done in 3 countries across Ireland, Canada, and UK. They randomized almost 900 patients into conventional fractionation 4 weeks or 8 weeks versus 5 weeks. So in both the group, the patients were well balanced. Median age was 70 years, and most of the patients, almost 90%, were in the intermediate risk group. And in this trial, they didn't allow for any ADT as well. So last year, they reported their 2-year outcome, which was their one of secondary outcome. And grade 2 plus GU toxicity was 27% in the SBRT arm versus 23% in the conventional. And the grade 2 plus GI toxicity was similar in both groups. At 24 months, the worst grade 2 plus GU toxicity was minimal. It was 2% versus 3%. And GI was also very low, 3% versus 2%. But what we look at the cumulative toxicity over 24 months, it was significantly worse in the SBRT arm. it was 18% compared to 11%. And the patient-reported outcome was similar in both cohorts in terms of the GI and GU. There was no difference. And recently, they have reported 5-year outcome at ASTRO, which is still not published. So what they have shown, that was the primary endpoint of 5-year biochemical failure-free survival. There was no difference between conventional radiation 4 weeks or 8 weeks versus 5 fractions. It was 95% in the low and intermediate, and 90% were the intermediate risk group in this one. Similarly, the toxicity was very low as well. It was 3%, grade 2 plus 3% versus 5%. GU and GI toxicity was less than 1% at 5 years. For prostate SBRT in high-risk disease, we don't have any phase 3 data so far, but what we can see is that there is 7 phase 2 trials which have reported their outcome of 344 patients, and all were from the USA. So median follow-up of almost 4 years. The late grade 3 plus GU toxicity was 2.3 and GI was 0.9%. And the 4-year biochemical relapse was 82% in this high-risk group, which is quite good. So far, there is no trial reported, and in the next few years, I don't think we will have any trial which will report outcomes for high-risk cohort. So the question is whether we can compare SBRT with the surgery. So again, PACE from UK, they have a trial. Initially, the trial was planned for 250 patients, but because of COVID, it was stopped at 123 patients. So they recruited patient and randomized to surgery versus 5 fraction SBRT. And if we look at the patient characteristics, well matched in both groups, median age was 65, and almost 90% of the patients were intermediate risk group. And if we look at the toxicity, which was their incontinence rate, if we look at the previous talk where Dr. Qazi was mentioning that they have only 3 out of 200 patients with incontinence. But if we look at the randomized published data, the incontinence rate, even with the robotics, are quite high. And in this PACE trial, all the surgeries were done at UK, and almost 80% as robotic surgeries. And even then, 2-year patients, almost 50% of the patients were using pads at 2 years, which means they were having some form of incontinence compared to 5% for the SBRT. So even with the robotics, it depends on person to person. The toxicity can be from very low to very high. The proportion of patients with small to moderate GI issues was more in the radiation, which is expected because of giving radiation to the rectum. And in surgery, we don't have any GI intervention. So that's why we expect very minimal toxicity for GI. I will skip this radiation portion and move to the so we look, the question is, so from 8 weeks, we are down to 5 treatments, 5 outpatient visits. Can we further reduce it? So there are phase 2 trials of 20 to 30 patients who have assessed 5 versus 2 fractions. And so far, they have reported quite acceptable toxicity. There is one phase 3 trial which is going in UK, which is comparing 5 versus 2 fractions. So that one will most likely, there are chances that maybe in next 5 to 7 years, it will be 2 outpatient visits for prostate radiation. The question is for the high-risk patients, when we have to treat nodes, whether we can treat pelvis with 5 fractions. And if we see the rectal data where we have given 25 in 5, which is well tolerated for new adjuvant settings. So we don't have any large phase 3 trial, but we have few phase 2 small data which have shown acceptable almost 30% of grade 2 toxicity for GI and GU. And so far, there are few trials. One is from Tata Memorial, which is ongoing. They have reported their initial results in ASCO this year, and they have reported quite comparable results with the 23 fractions, but we are expecting longer results in coming few years. This one I will skip as well. So from this 10 minutes talk, I can say that 5 to 7 fractions should be considered standard of care for low to intermediate prostate cancer. and it is endorsed by all relevant guidelines. And mainly, it was basically COVID which have accelerated the use. Less forgiving, so make sure that we have good quality assurance, good selection of patient, and the patients with the the obstructive symptoms, they should be offered more 20 fractions rather than 5, and image guidance and motion management should be the key. Thank you very much.
Thank you.
So thank you, everyone. So now I would like to invite the speakers to the stage, and we will take the questions. So do we have any questions? Yeah.
Yeah.
Kelly.
Thank you for the wonderful talks. I think it's a shame that people have left, but this phase B trial obviously was monumental, particularly showing equivalence basically. How do you envisage, I mean, we are struggling in UK, obviously, with brachytherapy and, with SBRT. And I literally asked my urologist on the day that it was published, tell me, how is it going to change the practice? You're looking at hundreds and hundreds of patients that you were offering brachytherapy. And now we are saying, well, actually, SBRT is as good. Are you, what is, the thought process in Australia? Are you going to see a switch altogether? And how are you going to go?
Yeah, so this is a good, like at Peter Mac, we have LDR and HDR as well. So at the moment, as a institutional, as a departmental policy, we haven't fully implemented SBRT. And the only reason is, like, if we have to start it, I think personally, if you give patient option of 5 outpatient visit versus 2 HDR, most likely patient will go for 5 fractions. So in Australia, there are 2 or 3 centers who are doing brachytherapy, and they are the centers who are doing very low numbers of SBRT. But now, and so one trial, Ninja trial, which is going on, which is basically the reason for doing that was implementing prostate SBRT in Australia. So phase B now, I think in Australia, most likely HDR brachytherapy will be limited to 1 or 2 centers. But if we look at the patient preference, I personally think it will be quite tricky. So mostly centers maybe will have to roll back their HDR or LDR. And particularly if we look at the dual saber trial, which is looking at 5 versus 2 fractions. So if we went down to 2 fractions, so if the person who is not going for surgery, why to get them for 2 anesthesia and 2 interventions for HDR? And indications are almost the same. Low volume prostate size, better no obstructive symptoms. So I personally think SBRT will replace HDR, and it will be in the end patient choice. But I personally, I'm not doing HDR brachy, but one of my colleagues. So at Peter Mac, I think as a department, we are holding back just because of HDR. And there is, and I think in terms of outcomes, it's like phase B 95%. I don't think we can get more than that. And it's,
and now that's fine. People in full context, people in big trials, this takes 2 days up to an hour and a half.
yeah. Yeah. And in Australia at the moment, like in UK, I know that like fast forward for breast is 5 fraction is the standard, but in Australia still it's 15 fractions, and the reason is just being paid per fraction. So there is a revision going on. So early from start of 2024, it will be based on intent, radical versus palliative, rather than number of fractions. So irrespective, you will offer 40 or 5, you will be reimbursed the same amount. So that will, I think, give a quite significant shift in terms of 5 fractions.
I have a question
Professor
regarding
Jacob.
high-risk prostate cancer. As we know, there is always risk of micrometastasis to the lymph nodes. So do you have any data to support external beam to the pelvis and the SBRT boost to the prostate? And if there is any data, then does have it shown
Look,
any impact on the biochemical?
I think in if you look at for high risk patients, we don't have any phase 3 data. So there are some small phase 2 trials from USA which have shown good biochemical control for the prostate high risk. But I think if we are still, we don't know whether 5 fraction is safe for the pelvis or no. So if we are giving 23 fractions to the pelvis, why not to treat 20 fractions to the prostate and 20 fractions to the node? And which is, I think, the standard in UK. So to 60 or 62 in 20 is the standard in UK, irrespective of risk. But in Australia, still we are 8 weeks, which Alison Tree was quite surprised when she was there last. So 20 fractions, I think, is a, if you want to go for the prostate plus pelvic nodes, 20 fractions, 42 to 44 in 20, and prostate 60 to 62, depending on low or high risk.
Thanks, Ali, for such a wonderful presentation. As a radiation oncologist, I mean, all these patients with prostate who are being treated with SBRT, they are going to be long-term survivors, majority of them. Does it worry you in the long term what the late effects are going to be in these cases? It's just something which always bugs me.
Phase we presented the 5-year outcome. So there is toxicity of less than 5%, but still we don't know the cumulative toxicity. So the cumulative toxicity can be anything between 10 to 20%. But the only thing which worry me is because we are assuming prostate has low alpha beta, like alpha beta ratio of 1.4 or 1.3, and all the late responding tissue, which are basically the sphincters, the pelvic diaphragm muscles, all have low toxicity as well. So we don't know, maybe in 10 to 15 years down the line, we will see a more toxicity. So it's a bit, what you call, like you can say, like we feel attracted, but there are so many uncertainties about it.
Some of these patients are in their 50s and with a life expectancy approaching 85. You can expect these patients, most of them, to be alive in 30 years' time. And 30 years down the line, 2 fractions, hopefully you will do their follow-up, we won't be around. Thanks.
Yeah, and mostly like in, if we look at like normally, I personally less than 65, I always prefer them to go and get the surgery rather than offering radiation.
Dr. Mohammad, thank you very much for nice talk. Do you think the SBRT, because of its high precision, low toxicity, high dose, will challenge the robotic radical prostatectomy in the coming years?
I don't think so. In the end, like, look, as what I perceive, how I interpret all the data, like human beings, as human beings, we are not born to get the radiation or get the surgery. So as being a physician, I think we should give the patient, let them know what are the options and let them decide. Because I know that, so for, if we look at the surgery, the more complications are incontinence, which in good experience centers, less than 5%. Sexual, definitely the sexual is the main issue. Like almost 80 to 90% of the patient, even with the robotics, you end up with losing the erection immediately. So some patients, maybe they will value having a good sexual life for 5 to 7 years. So those are the candidates for radiation. But if a person who is not worried about sexual issues and worried about GI issues, so I think surgery will be this. So both will stay. I don't think radiation will take over surgery or surgery will take over radiation. So both will stay there. It's just patient's perspective, it will change. But less visits, maybe patients will be more attractive towards radiation.
Thank you.
Dr. Dick is on? Or? Okay, can I ask a question?
Yes, thank you very much, Dr. Ali. So we have got a few questions for Dr. James. So Dr. Ali also wants to ask a question. So first Dr. Ali will ask, and then we can take the online questions as well.
Hi, Dr. James. Just quick questions about the high volume disease for metastatic setting. Like you know, from our low volume disease, we know that giving 55 in 20 or 36 in 6 is a well tolerated, very minimal toxicity, and we can reduce the local symptoms. You think there is a role of giving radiation for high risk disease to delay the need for any intervention for obstructive symptoms? And particularly, we know that if the patient has local symptoms, they didn't respond well to radiation at that time.
Yeah, that's a really good question. So there's two recent bits of data supporting that. So within Stampede, we did a randomization to radiotherapy to the primary metastatic disease with the schedules that you just described. We've just done an analysis hooking up the data from that part of the trial to long-term NHS follow-up data. And what we very clearly see is roughly a halving of urological complications. So we just presented some data at ESMO on the need for nephrostomy tubes for severe lower tract obstruction, and basically it halves. Separately in piece one, they did the same sort of analysis, but a broader range of urological outcomes, and saw exactly the same effect. So I think it's reasonably clear that you get a big benefit. I guess where the gray area is if you've got very extensive metastatic disease and not much in the way of urinary symptoms, you may never get problems with the prostate. So you may well be over-treating those. On the other hand, I think if you've got a bulky primary with lower urinary symptoms, I personally now have a very low threshold for giving radiotherapy up front to those patients using the schedules you describe.
Thank you.
Thank you, Prof. James. So we have got another question from one of the online attendees. So as you know, we are a low-income country. So the question is, how do you compare abiraterone at a dose of 250 milligrams per day to 1000 milligram per day? So what's your experience about that?
That's a really, really good question. I've just been chairing a commission for the Lancet on prostate cancer globally, and we've ended up focusing extensively on the issues in low and middle income countries. The question being, how do you get the best value for money with more limited resources? So this is one of the recommendations we make, is that as far as the data is not 100% robust, but insofar as the data exists, 250 mgs of abiraterone daily is probably just about as good as 1000 mgs. And of course, at the generic price, you can get a lot of abiraterone for your money, even in low-income settings for that. And that seemed to us to be a very strong thing to be worth recommending. The parallel recommendation we made as well was around GnRH analogues. And this actually applies in high-income countries as much as it applies in other income settings, which is that if you're on long-term ADT, men usually don't like the idea of surgical castration as an initial therapy. But actually, once they've come to accept that it is irreversible, they're going to be on ADT forever. And if you're in a setting where you're having to pay for your Zoladex or whatever it is you're getting, it makes a lot of sense to offer those men orchidectomy, especially a subcapsular orchidectomy, as an alternative. So that potentially saves you a lot of money that you can then use to pay for treatments like abiraterone. And to be honest, this saves money even in the high income setting. We spend a lot of money on Zoladex, probably unnecessarily. So I think there's a number of strategies like that. Probably the same applies to enzalutamide as well. Probably you can give a lower dose of enzalutamide. So I think there's a lot of medicines that there's a lot of scope for looking at doses other than the licensed dose in order to extract value for money, really.
Thank you. So we have got another question from one of the online attendees again. So they are asking that in what setting the PSMA PET treatment can be used in metastatic prostate cancer?
Yeah, so this is a very interesting treatment, and again, this is a treatment where the costs can vary enormously. So the licensed treatment, as tested by Novartis in the Vision trial, has an approval in most jurisdictions for men who've already received an AR targeting therapy and a taxane. In some jurisdictions, like the UK, the license actually extends to men who've only received an ARSI and no taxane. The rationale being that there's no reason to think that the drug works less well if you haven't been exposed to chemotherapy, and the recent PSMA-4 data supports that. And not all men are fit for a taxane. So to put people through a taxane in order to get access to PSMA lutetium is probably unnecessary. The main issue with PSMA lutetium is the cost. It's in sort of high income countries, it's extraordinarily expensive. You're looking at, in the UK, about £20,000 per cycle, with a maximum of 6 cycles. So clearly you're looking at spending a very large amount of money. It is possible to produce what you might call homebrew PSMA lutetium. So nuclear medicine departments familiar with doing radiochemistry can potentially conjugate their own radioisotopes to the same tracer that you use for PSMA PET scans. And this is widely done, I know, in India, for example. So this is probably possible to get cheaper versions of PSMA lutetium than the branded form.
Thank you very much. Now we have got another question related to radiation oncology. So Dr. Ali, if you could come on the stage. So they're asking, can we offer PACE-B regimen to unfavorable intermediate risk category?
So if we look at the PACE-B, so PACE-B, they didn't include the unfavorable risk because ADT was not allowed. But all the intermediate risk, they are recruiting for PACE-C, which is a PACE node treatment. But if we see the hypo-RT trial, which was a 7 fraction, so 89% of the patients were intermediate and almost half of those were unfavorable. So you can personally, I think, you can offer 5 fraction for unfavorable intermediate with 6 months of ADT as well. But if you want to omit ADT, then maybe you can think about boosting the dominantly, and if you can see on MRI. But otherwise, you can definitely offer 5 fractions or 7 based on hypo-RT.
For now. We have got another question for Prof. Hussain. So we talked about the ocular toxicity of enfortumab vedotin. So the question is that what is the protocol to monitor the ocular toxicity? Because we don't see these things very commonly with chemotherapy. So this is a different thing. So is there a specific protocol to monitor it?
Yeah, I think the key thing is these drugs have class effects. We know we have got quite a bit of experience with FGFR inhibitors, for example. Many of the colleagues would have used. And again, the way to deal with those is basically having a close ophthalmology review. And that is, again, we ask about in EV as well, because patients who have been treated in trials, there's a very clear protocol about referring them for ophthalmology review earlier. So while you ask about the ocular changes in visual acuity and anything like that, but there's a very clear protocol. So the key thing is really have a low threshold to be in touch with ophthalmology. And again, one thing to highlight when we spoke about immune checkpoint inhibitors and we're talking about FGFR inhibitors, and now moving into enfortumab vedotin, it's really important to have a network of multiple specialities working together to look at those toxicities and identify those toxicities and treat them early. The best, because quite often if you are not managing those toxicities early, that can lead to significant detrimental effect, which may lead to a bad experience. You may have experience of n equals to 1, which if it's very poor, that can lead you to consider whether you should be treating that patient with the drug or not. So I think there is a protocol for that, but the key thing is that you have an ophthalmology who knows about these drugs or and is basically contactable. So we have built up a sort of a friends who I can call at late in the evening if I'm worried about IO-induced colitis or EV-induced ocular toxicity or dafitinib-induced. Sometimes it happens, ocular eye visual changes, allos. A lot of those symptoms could be non-specific, but the key thing is not to delay getting the support from your specialty colleagues.
I think people will have so many other questions in their mind. We can take online questions and the speakers can then give the responses online. But for now, I think we should be closing the session. Thank you very much.
Maria, I just want to say thank you to Nick James, really. Thank you, Nick, for being part of this symposium and having
welcome.
your Stampede trial and to talking about all these trials where you have made such a huge impact with level 1 evidence that you have generated. And hopefully we'll see you in Pakistan at some point.
I really, really wanted to come, but as you know,
You're still there, Nick.
I've had a lot of travel. But thank you very much. And
thank you very much. So
Yeah.
all 4 papers were extremely nice. Thank you very much for coming. Thank you, Muhammad Ali, for coming. And thank you, Nick James and the other colleague, Hassan Qazi, for excellent talks. Very good insight.
Thank you.
Thank you.